Hello, I'm Dr. Mustafa Hasoun. Today, I'm going to talk about anti-VEGF versus steroids in diabetic macular edema. I have no financial conflict of interest to disclose. Now, VEGF has been linked to leakage of retinal vessels and hence to formation of retinal edema. So, using anti-VEGF drugs for treatment of DME was rational. At present, anti-VEGF agents are the first-line treatment for DME. Since 2005, bevacizumab was used and that agent is off-label. In addition to bevacizumab, there are multiple agents like ranibizumab, aflibercept, brosozumab, and faricimab in 2022. Why anti-VEGF in DME? I will talk about some anti-VEGF landmark studies. If we start with bevacizumab, bevacizumab is the most cost-effective treatment option among anti-VEGF medications, according to the POLT study, which showed the superiority of bevacizumab over laser in treatment of DME. And the RCR.net protocol T showed that there was no significant difference between aflibercept and bevacizumab and ranibizumab in treatment of DME, especially the visual acuity was more than 20/40. All of them have the same final visual improvement, but in case of visual acuity less than 20/50, aflibercept was more effective. Now, if we move it to ranibizumab, according to the DRCR protocol I, in the left photo, the bottom right, we can see that ranibizumab was more effective than triamcinolone. And according to the same protocol, the vision gains maintained throughout 5 years of treatment and follow-up, even if we increase the interval between the intravitreal injection. Now, by talking about extension protocol S for 5 years of follow-up, ranibizumab therapy for VDR is non-inferior to BRB at 5 years for change in visual acuity. Ranibizumab is also provided several benefits over BRB throughout 5 years by decreased peripheral visual field loss, fewer vitrectomies, reduce the incidence of DME, and improvement in diabetic retinopathy severity, and less needing for doing aggressive BRB. In this photo, we can see the main change in the visual acuity with baseline DME and without baseline DME, and the difference between ranibizumab group and BRB group. Aflibercept. This agent, the Da Vinci study phase 2, showed that agent was effective to treat DME. Faricimab is the first one to target two distinct biological pathways, angiopoietin-2 and VEGF-A. And Boulevard study showed that we can increase the time and the interval between the intravitreal injection by using this agent comparing to the ranibizumab. Yosemite and Rain study showed extended dosing up to every 12 to 16 weeks in more than 75% of patients with a DME, and that was interesting. Now, if we were to talk about steroids in DME, we can start by talking about triamcinolone. Protocol B of the RCR showed that the laser was more effective than intravitreal triamcinolone regarding visual acuity. And in addition to that, we cannot forget the possible side effect of intravitreal triamcinolone, which could be rising intraocular pressure more than 10 millimeter mercury in more than 33 patients. And cataract surgery was done by 80% of patients who treated with triamcinolone. And again, according to the DRCR protocol I, visual acuity in pseudophakic eyes given intravitreal triamcinolone was better comparing to the phakic eye, but that just for the first 6 months, and later on ranibizumab and anti-VEGF again became effective in this group. Extension of DRCR protocol I for 5 years of follow-up. Ranibizumab groups remain fairly stable, and using laser or triamcinolone plus prompt laser to treat central involved diabetic macular edema followed by very diffuse ranibizumab does not achieve the same long-term vision improvements as the initial ranibizumab therapy group. And this photo showed that two group, laser 1 and triamcinolone 1, which is converted and switched to ranibizumab after refractory DME, did not achieve the same level of visual improvement comparing to the initial ranibizumab therapy group. And Hamid Ahmadi's study showed intravitreal bevacizumab with or without triamcinolone for refractory DME did not add any significant additive effect later during follow-up. Now, dexamethasone implant MEAD study showed higher rate of side effects, and this implant in real life practice just effective for 3 to 4 months. Before Dex study showed that bevacizumab was more effective regarding visual acuity comparing to the DEXA implant in all eyes. But in subgroup pseudophakic eyes one, dexamethasone implant was a little bit more effective comparing to the bevacizumab. Protocol U, combination of treatment for anti-VEGF with dexamethasone implant in refractory or incomplete responders showed that adding of dexamethasone to ranibizumab patient did not show it any more effective comparing to the ranibizumab alone. So ranibizumab alone was more effective regarding visual acuity. But if we look to the right photo, we can see that that combination sure make more dryness of macular edema, but did not correlate it with gaining more visual acuity. Fluocinolone acetinoid implant showed cataract progression was in 90% of patients, and more than 60% of patients which treated with a fluocinolone acetinoid implant have a intraocular pressure increased and rise in intraocular pressure more than 30 millimeter mercury. Fluocinolone acetinoid ILUVIEN, which is agent, has a FDA approved just in eye previously treated with a corticosteroid and did not have any clinical significant rise in IOP. So finally, intravitreal steroid had poor adverse effect profile vs anti-VEGF therapy by increasing intraocular pressure, glaucoma, cataract, reactivation of steroid endophthalmitis, and finally, needing for close follow-up for any possible side effect and complication which increase the burden of the patient. Finally, anti-VEGF therapy is effective by improved visual acuity over steroid and laser, save by there a little bit of risk of cataract progression, ocular hypertension, and glaucoma, have set new standards of care for patients with a DME as the first line of treatment for naive DME and in refractory DME by switching from agent to another agent of anti-VEGF agents. Cost effective by using bevacizumab, which is cheap, effective, and safe, and sustainable effect by using ranibizumab aflibercept, and reduce the number of injections throughout the years of treatment, and avoiding using steroid implant, which is increase the financial burden for it and possible complication which need to treat it and follow up. May also prevent or slow the worsening of diabetic retinopathy status and need for BRB in subset of patients with a DME. Thank you.